So I'm Dr. Abdul Ghafoor. I'm in UAE from almost 25 years, graduated from India. And we are running few medical centers and a hospital, which is Amina Hospital, 100-bedded in Ajman. So that's it.
Thank you.
So today meeting is to discuss the protocols, which I already sent to you guys, created by Dr. Quays. So we are going to discuss the protocols in COVID-19. And if we have time, we can also have a quick little discussion about the stem cells protocol in COPD and in other conditions also. But later on, Dr. Chris will send us the more details and will email you guys. So just 3 more minutes and then we will start the meeting. So meanwhile, if Doc, you have any questions, both Dr. Zaman and Dr. Ghafoor, you can also ask Doc so that he can, later on talk on also about that.
Yeah, not any immediate questions per se. I just wanted to say via introduction that in this very difficult time for all of us in COVID-19 globally, I think this particular forum that we have right now is really an example of how we need to exchange information globally to help our patients and to help our nations. And so this transcends any other geopolitical or geographic type of limitations in medicine. We need to be able to exchange information and ultimately better our patients and help mankind. And so from that perspective, I'm more than happy and willing at any point in time to exchange information, provide you with protocols, and assist you in any matter that I can. And I think everyone's experiences really factor into this. I'm sure Dr. Ghafoor in the UAE has unique experiences. Dr. Zaman has unique experiences. And so I think it's really important to exchange information, as I mentioned, and ultimately move the science forward and move the practice forward for our patients. And then separate from COVID-19, well, somewhat related to it, but clearly regenerative medicine has a role to play, and I think likely a very big role to play in those patients who will be recovering from COVID-19, but will have residual health issues such as ongoing pulmonary distress, lung scarring, etc. And so regenerative medicine, I believe, will have a very important and essential role to play in how we can also assist those who are recovering from the disease and not just those who are currently afflicted from the disease. So those are just a few thoughts I wanted to put forth.
Yes, so Doc, I think we should start the meeting. Yes, Doc, we can start. You can start with your protocols of.
Yeah, so the first scenario is one that we find ourselves in globally, and that is, of course, with patients who are acutely affected by COVID-19 or hospitalized and oftentimes mechanically ventilated, certainly have signs of end organ issues, not just pulmonary, but cardiac and renal and others. And so in that specific environment, the question is, what can we offer these patients from a regenerative medicine perspective to potentially augment their treatment, not to substitute necessarily for current treatments such as remdesivir, such as corticosteroid administration and others, but rather what can we do to augment these treatments and hopefully improve patient survival. And so with regard to that, I've looked at the science globally, and currently, as you can see, very much is published and very much is published rapidly so we can get information out globally. And that's a good thing. What is maybe a bit of a drawback is because we're in such a rapid timeline right now where we need to get information out scientifically, they're not necessarily always peer reviewed, and they may not necessarily have the best scientific designs, but it is a sign of the times where speed is of the essence. So unlike many other chronic diseases where we have certainly the benefit of time and being able to have clinical trials that are very thoughtfully designed and elegantly designed, etc. Right now, we're in a scenario where we have to be able to bring treatments to our patients more rapidly than what we're usually doing. So having said that, there are a number of different strategies from a regenerative medicine perspective that can be employed for patients who are critically ill with COVID-19 and also those who are perhaps only mildly or moderately affected by COVID-19. So those are two different groups of patients. Now, the first group, the hospitalized patient group, may certainly consist of those who are critically ill. And from that perspective, a more aggressive intervention is likely needed, as opposed to those who are mildly or moderately affected by COVID-19, who may not be hospitalized, but may have pulmonary complaints and others. And in that particular case, a different regenerative medicine strategy can be brought to bear. So let's focus perhaps first on those patients who are currently critically ill with COVID-19 to see what potential strategies from a regenerative medicine perspective we can pursue. The protocol that I had forwarded to Dr. Rosina was a protocol that was based on a very specific stem cell population. And in fact, in Dr. Ghafour's geographic environment in the UAE, as I'm sure you're well aware, the Abu Dhabi Stem Cell Center had developed a protocol that utilizes very small embryonic-like stem cells as a treatment method for patients afflicted specifically by COVID-19 pneumonia. And so what I've ultimately done is I've developed a slightly different protocol that is perhaps a bit more simplistic, but also goes back to the core of these particular types of stem cells. Having said that, let me introduce this particular cell population called very small embryonic-like stem cells. These are not embryonic per se, so they're obviously not derived from embryos. They're actually adult stem cells, but they are remnants. They're remnants of our original embryonic stem cells. What makes these particular stem cells unique is the fact that they do carry pluripotent embryonic type markers, which means that they have the ability to differentiate into all three germ layers, meaning ectodermal, mesodermal, and endodermal cells. So what would make these particular cells unique in COVID-19? There are several aspects that would be appealing. One aspect is that these particular cells can have a rather rapid role to play in pulmonary regeneration, specifically at the level of alveolar 2 cells. These are surfactant-producing cells that are typically the target of SARS-CoV-2 because they carry a very high density of ACE2 receptors. So why would these particular cells then play a role in this particular circumstance? Well, one thing we know about this cell population is that one, they're very potent immune modulators, which will certainly be an advantage, especially as we're afflicted with a cytokine storm environment, specifically with very high levels of interleukin-6, among others, and tumor necrosis factors. So from a standpoint of regulation of the local cytokine environment, there certainly is a benefit to using these particular cell populations. The other thing that would be appealing for this particular cell population is the fact that by design, they're essentially a remnant of embryonic stem cells, which have a role to play in the face of critical organ disease and ultimately become active in that environment. If we can activate these cell populations, which typically circulate in the inactive state, if we can activate them, and we can do so exogenously, by exposing them to low temperatures and to hypoxia, and then provide them back into the body as a treatment, we now have an active pluripotent stem cell population that can certainly potentially help us in terms of regaining lung function. So sorry for the very broad introduction, but I just wanted to mention a few words about this particular cell population. I'm sure there are questions.
Yes, hi, Dr. G. So Dr. Chris, Dr. G, Dr. John Glenovich also joined us. So Dr. John, Dr. Ghafour is from UAE with us, and Dr. Zaman from Bangladesh is with us. And Dr. Chris, Dr. Zaman has a question that he said if you can have a PowerPoint, you can share it with us. So
certainly, let me bring up, instead of a PowerPoint, let me bring up the protocol itself. So let me.
Yeah.
Dr. Cruz, just to understand it better, so I will put a small question. In Abu Dhabi, what they did was they extracted the patient's plasma and they introduced to the same patient through some nebulization, so directly into the lungs. That is how they did, and they got the patent for that. And you told that they are using embryonic stem cells, and in your protocol, you're not using the embryonic stem cells. So what is the difference between these two then?
Yeah, so the protocol from Abu Dhabi uses very small embryonic-like stem cells. They're not embryonic per se, but they're adult stem cells that still have embryonic surface markers. So that is what they're using in that protocol. The aerosolation, meaning aerosolizing them, the reason for that is twofold. One is obviously to get them directly exposed to alveoli. The second reason is that cell population, these particular very small embryonic-like stem cells are in fact very small. They're less than 5 microns in diameter. And so the thought process is if you give a cell population intravenously that then goes to the pulmonary bed, due to their small size, they will rapidly go through the pulmonary bed and not be entrapped in it. The idea with other larger stem cells, larger diameter stem cells, such as mesenchymal stem cells in the 15 to 18 micron size, if you give them systemically, at least transiently, you will trap them in the pulmonary bed and they can have some activity in that sense. So these are two of the reasons why this particular protocol relies on aerosolization. But just to clarify, they're not embryonic stem cells. They're embryonic-like stem cells in an adult body from peripheral blood. Yep. You can isolate them, by the way, also from bone marrow. In fact, you can isolate them more efficiently from bone marrow, but peripheral blood is clearly more convenient.
Thank you.
Yeah, I have a question. You know, like they use the inhalation way of using the stem cells. So which one do you prefer, the peripheral or the inhalation? They both have the same effect?
So for a very small stem cell population, as I mentioned, these are 5 microns and less in diameter. I think inhalation is a very good route to take. Again, we're trying to deliver them as close to surfactant-producing endothelial cells in the pulmonary alveolar environment as we can. So I think that's a good route for that. If we chose a different stem cell population, such as Muse cells, which we can discuss as well, these are much larger. They're, again, 15, 18, 20 micron in diameter. Those cells I would give systemically. I would give it by IV administration. And again, the reason would be they're somewhat permanently, somewhat transiently trapped in the pulmonary bed and will take effect there. Wow. Now, if you were to ask me, what about a growth factor treatment, right? And clearly, growth factors have a role to play and likely a very important role to play in COVID-19 pneumonia. The question is, what types of these should they be and how should they be administered? And so from a growth factor perspective, the ideal environment would be that we use a very immature growth factor cell source. And if you ask me what the ideal one would be, I would say likely umbilical cord blood plasma. You can actually harvest very unique proteins from umbilical cord blood plasma, and now you have a very potent growth factor source. That's not always possible depending on where you are and what you have access to in terms of biologics. But if you do use a growth factor-based, let's say a platelet lysate type, or just a plasma type of treatment, then aerosolizing it, again, makes a lot of sense. But having said that, I would still use part of the dose systemically as well, because we have to recognize that COVID-19 is also a systemic inflammatory disease, and it's not just a pulmonary disease. And so addressing some of the other issues simultaneously, I think, would be a good strategy.
Right. Dr. Zaman, if you have any questions regarding these protocols.
No, still I have no question. It's continued.
Okay. So
Yeah, so this is, a protocol for a very simple autologously based approach in COVID. It's a low risk approach from a standpoint that this is an autologous source of biologic, but it's also a relatively conservative approach. If you asked me, and let's just say we can divide patients who are hospitalized with COVID-19 into multiple different groups. Let's just look at the most critically ill patients. Let's look at those who are not just mechanically ventilated, but also have multi-organ failure. So these patients will have some degree of cardiomyopathy in addition to bilateral pneumonia, in addition to compromise of renal function. So really, this is a very dire situation. And unfortunately, that particular group has a very high mortality rate, somewhere above 80%. The question is, what potential role can regenerative medicine play in these particular patients? And I'll give you an example. I'm working with a group of these types of patients with a physician in India right now. And the scenario is, and I think this is becoming a more common scenario, is that the critical care physicians at some point literally say, if there's anyone in my hospital who has any other ideas, any other thoughts, any other experiences, specifically in the realm of regenerative medicine, please help me. And so to give you this scenario, this particular physician is in a very large hospital with 52 ICU beds and a mortality rate approaching 25%. And in this environment, they've given him literally 10 of the sickest patients and say, we've given up on them. We have no other options for them. What is it that you can potentially do with them? And so this is a scenario now, I think, in some larger hospital centers in some countries that are terribly afflicted by COVID-19, where now there is a very unique role to play for regenerative medicine in hopes of providing some type of intervention that can save lives in patients who are hopeless at this point in time. And so beyond the protocol that we're looking at right now, there's several other strategies that we have employed in that specific environment. And one strategy is to actually augment bone marrow release of cells. And this is a very simplistic process. If you're familiar with filgrastim, which is Neupogen, which is GCSF. So GCSF is, of course, commonly used by injection to promote bone marrow mobilization of cell populations, not just stem cells, but also other cell populations like white blood cells, etc. And so one strategy we're employing right now in these critically ill patients who are really not tolerant to procedures per se, is to say, why don't we stimulate their bone marrow aggressively with filgrastim, i.e. with GCSF? And what will be the thought process behind that? Well, if you use GCSF, you're globally mobilizing cell populations, both on the myeloid side as well as on the hemoid side, to aggressively augment peripheral blood with all types of cell populations. Well, what specific cell populations are we interested in COVID-19? Well, we're certainly interested in B cells and T cells, so lymphocytes. Specifically, what will happen with GCSF is you augment neutrophils, you augment specifically T lymphocytes, and specifically CD4 and CD8 T lymphocytes, which then can convert into cytotoxic T lymphocytes and also a natural killer cell population. These types of lymphocytes are critical in the defense against COVID-19. So specifically cytotoxic T cells and natural killer cells. What else do we want the bone marrow to mobilize? Well, we want the bone marrow to mobilize B cells, B lymphocytes as well. And why do we want that? Because what will happen in the thymus gland is that we now can produce a stronger antibody response. And so this is a very simple drug. Filgrastim has been on the market for 3 decades or more. It's very inexpensive, and it's a simple injectable type of treatment to mobilize our bone marrow. This is a strategy that so far has not been employed, but it's a very simple a low-risk intervention, and it's something that we can augment in addition to the protocol we're looking at right here, where we're using specific stem cell populations. So I'm just giving you a little broader picture as to how we can potentially bring some combination treatments to bear. Now, if you were to ask me, okay, well, these are the most critically ill patients. What about patients who are not critically ill? What about patients who have mild to moderate symptoms? Let's say they have only respiratory complaints and maybe not even at the level of pneumonia, but let's just say at the level of some lung inflammation and maybe just the beginnings of some infiltrates. What can we do with those patients to prevent them from going onward in the disease and having severe disease manifestation? Again, a simple intervention with those patients would rely on augmenting their immune system. How can we augment the immune system to potentially prevent this progression? And certainly, again, bone marrow stimulation would be one strategy. A second strategy would be a growth factor treatment. It doesn't have to be a stem cell treatment because we're not at that point. We're not at the point where we need regeneration of organs. We simply need an augmentation of the immune defense. And so several prospects have arisen in that realm. So one would be, for instance, to use actually what is called resveratrol. I don't know if you're familiar with resveratrol as an anti-aging compound, but resveratrol and quercetin are both used commonly in the anti-aging arena. However, if you look at the science in terms of the antiviral activities, both of these compounds, resveratrol and quercetin, have actually been used in vitro studies in SARS-CoV-1, the original SARS outbreak, and in MERS. And in both scenarios, from an in vitro perspective, have actually shown significant activity. So if you were to ask me, what can we do with those who have relatively mild COVID disease right now? Some very simple things we can do is we can stimulate the bone marrow. We can potentially augment them with resveratrol or quercetin or both, and ultimately provide a stronger host defense against SARS-CoV-2. So these are just some additional thoughts.
Okay, so Doc, like this is about we are taking in this protocol is about the peripheral blood, which we take it from the same patient, right?
Correct. This is an autologous type protocol. It can also be used in ABO matched allogeneic environments. As you can imagine, the sicker the patient is, the more beneficial would it to have peripheral blood from a donor. The ideal donor blood actually is umbilical cord blood, which can be processed in the exact same fashion to harvest these cell populations. If a patient is moderately ill from COVID-19, this protocol, I think, can still be utilized successfully. But in more advanced cases, I would suspect we should reach for either a younger donor, allogeneic blood, or umbilical cord blood.
Okay. Dr. Kapoor, if you have any question, because umbilical cord blood in UAE, I don't know whether they allow that practice or not. Is it any religious or ethical difficulties in that, or? You are on mute, Dr. Kapoor.
Sorry.
Yeah.
Sorry, I'm not aware of any such ethical issues going on now, but maybe I have to check and reconfirm with the Ministry of Health.
Right. Okay. Yeah. Because doctor discussed about the three conditions, that the one most severely ill person and the moderate and mild. Dr. Chris, I have one question that in case if because they say that like if you are using the autologous peripheral blood, then the patient is already suffering from the disease. The question arises that he's suffering from disease, so his blood is good for use, or no, we shouldn't, because it is contaminated. I mean, it is affected by the virus.
Yeah, so when you look at how SARS-CoV-2 infects us, primarily the infection is at the level of airway cells, specifically endothelial cells in the lower airways, not as much in the upper airways even, but it is not like septicemia, where you have bacterial contaminants in peripheral blood and the systemic circulation. So by and large, SARS-CoV-2 will target endothelial cells because it needs ACE2 receptors to enter a cell. So ultimately, cell types that have ACE2 receptors on the surface are the cells that are directly infected by SARS-CoV-2. In the peripheral blood, we have really an extraordinarily low population of cells that actually carry ACE2 receptors. And this is why peripheral blood, by and large, is a safe source of a biologic. It's not the ideal source. The ideal source, again, would be umbilical cord blood and then plasma from there, but it's still a very reasonable source of blood.
Okay. And Doc, this protocol is a two-step. Like first we have first step is like this, and the second one, which is on this side, that the 800 platelet lysate protocol, which is given at this. This is the protocol for the platelet-rich lysate protocol. So right,
Correct.
we have to mix both of these, withdrawn blood.
Yeah, there are two reasons for that. So the platelet lysate piece actually has two purposes. One purpose is it actually acts as a culture medium for the V cells and U cell populations, because if you are familiar with platelet lysate as a culture medium, it's actually commonly used in the culturing environment because of a very high level of growth factors. And this is partly what we're doing here. We're bringing them together so that platelet lysate can act actually as a short-term culture medium. Now, normally, when we talk about cell culturing, we're talking about a scenario where cells are cultured for days to weeks. In this particular protocol, as you can see, this is really just an overnight cooling of these cell populations. So when you think of culturing, normally it's a longer term process, but even in this very short term overnight cooling of the cell population, this particular component, the platelet lysate component, will act as a short term incubating type reagent, if you will, or as a very simple form of an incubator. Now, the other reason, of course, why we combine this with platelet lysate is that we also have a growth factor portion in addition to a cell portion, as we discussed earlier. Each has an entirely different role to play.
Okay. So even, other than the COVID patients, we can use the same protocol for the other lung disease, interstitial disease patients?
To a degree, yes. I think this is very dependent on each patient. And I honestly believe that every patient should have a customized protocol developed. And so not a universal protocol per se. And even in the scenario of lung disease, there is a big difference between COPD, interstitial fibrosis, and on. They all really need different biologics approaches for them. So this is not a universal protocol that I would apply just generically to lung conditions. Now, specific to COVID-19 pneumonia, however, and the sequelae, which is lung fibrosis and lung scarring, right, post-COVID-19, I think this is still an adequate protocol, but I wouldn't translate this protocol into COPD patients or emphysema patients, et cetera. I think they require a different approach.
Okay, so this is the same protocol for even the post-COVID patient, because some of the patients, even after they recover, they still have some of the breathing problems and issues. So we can still use them as a mist or like inhalation and or either intravenous. We can use this protocol, right?
Yeah, certainly in general terms. Now, it depends a little bit on the scenario. So let's say you have a COPD patient who develops COVID-19 pneumonia, and subsequent to that now has two different pulmonary issues: exacerbation of COPD, and in addition to that, let's say interstitial fibrosis. In that environment, there may need to be some changes made to the protocol. And again, I'm trying to emphasize, that we need to be thoughtful about the specific pathology we're treating. And so again, in previous pulmonary morbidity or pre-pulmonary states, in addition to COVID-19 pneumonia, we may have a slightly different scenario. I think this protocol will be just fine for patients who have no early or underlying, I should say, pulmonary disease. And this is really a sequelae specifically of COVID-19 pneumonia.
Okay, so Dr. Naveed Mohsen is also with us. I think he has a question. Okay, Doc. So I have one more question about the activation. Like in UAE, like in the Sheikh Khalifa Hospital, when they use the stem cells taken from the peripheral blood and then they activate it. So this is the process, like which means from the activation of the peripheral blood drawn stem cells.
Yeah, so activating processes, if you look at it generically, you can activate what are called inactive or deactivated stem cell populations, and there are only a few really out there. U cells and B cells are the most common ones. By and large, what you can do is you can activate them by simulating physiologic stress, specifically hypoxia, hypothermia, acidosis, and the other activator, of course, is global tissue injury, which is very difficult to replicate. What we can replicate, however, is hypoxia and hypothermia. And so the typical activating mechanisms for these types of stem cell populations that are pluripotent in nature is hypothermia. It's the simplest thing we can replicate. And the threshold for physiologic activation is right around 4 degrees Celsius. And this is why that protocol has that number in it. Now, one thing I would recommend to do, however, is in addition to hypothermia, I would also place this in a hypoxic environment. And this can be actually done very simply. As you're aware, we use vacutainers for blood draw, every day, everywhere. Well, vacutainers are vacuum filled, which means they do not contain oxygen. And so a very simple way in this protocol to actually also introduce hypoxia is to take red tubes. Red tubes have no other anticoagulant in them. And these are BD made red tubes. So they're empty vacutainers. And an empty vacutainer is essentially a hypoxic environment. So if you are in a hospital or clinic environment where you don't have access to a hypoxic environment in a larger container form, what you can simply do is you take a red top, BD top, and what you do is you essentially place the biologic into it. So now you have a relatively hypoxic environment. So now we have two mechanisms to activate these cell populations, hypoxia and hypothermia simultaneously.
So Dr. Mohsen and Dr. John, Dr. Ghafoor, Dr. Zaman, if any of you have questions. Dr. Mohsen, you raised the hand if you have questions.
Hello, how are you? Hello, good evening. Can you listen to me?
Yes, we can.
Hello?
Yes.
Okay, that's fantastic. Okay, that's fantastic. Good evening, Dr. Chris Paulus and the wealthy participant and Dr. Zina. It's a great opportunity to hear Dr. Chris Paulus about the things. I was just wondering that, the patients that we encounter here of the COVID-19 in Pakistan, there are two kinds of patients. One are those which have got the native immunity and they've got a good immunity. So they come up and they sail through very well, and then they mount antibodies. So once we test them against the antibodies, they form antibodies, and then they are next to asymptomatic. And the second group is those which have got comorbid conditions and they don't mount antibodies. So I was just wondering that if we are aiming to treat very sick patients which are in the acute hospitals, obviously they are very, very infectious. So what is your protocol? Do you recommend it to the asymptomatic non-immune patients, or symptomatic sick patients, or both?
Yeah, it's a very good question. So this goes really more into immunoglobulins, perhaps, as far as a treatment methodology is kept in mind. So the question you had, was it specific to regenerative medicine interventions or more globally in terms of how we can treat them?
Well, about the COVID-19 because most of them, they are trying, and then the dexamethasone, and then they are on these anticoagulants like Claxin, things like that. So they are already receiving a cocktail of medications. So I was just wondering that how good we can use this against the convalescent plasma, because which is has been used in a very selected cases in Pakistan. So how we can separate that entity from this one, this RP from that? How we can make them a bit more selective and a bit more choosy? So if we can make the cohort of the patients that will give us a better response, so we can make the cohort of the patients symptomatic or badly symptomatic, are, those who are not requiring ventilatory support, or they have got the hypoxia episodes, or they have got less than 1/3 of the lung involved, things like that. So if we can have the clinical settings, and then we can try this therapy in 1 or 2 months, that will be more conclusive.
Right. There was part of this I didn't quite hear. Dr. Rosina, did you hear the entire question?
His question is that, okay, like there we have different patients, like some are who are in with different complications and they are in the hospital. Some are the one who came afterwards and they still are positive, or they have they are negative, or antibodies are present, or they are positive or with symptoms. So in that, can we use this for all? This is the same protocol for every one of them to use, or we just change or do something else, in this protocol?
Yeah, so good question. The specific protocol that we have discussed is really there for patients who are severely affected with COVID-19. As you mentioned, more than one third of the lung volume is affected with pneumonia. These are the sickest patients that require the maximum regenerative support, if you will. That's a different scenario from those patients who have some antibody response, IgM specifically, and who are actually dealing with COVID-19 reasonably well and are not likely to progress. So that's a separate patient population. The specific protocol we're looking at right here can be used in conjunction with convalescent plasma. And of course, the idea with convalescent plasma is to transfer some degree of immunity, primarily again on the IgA and IgM side, a little less on the IgG side. And so that can certainly be combined together. And they're very different types of approaches. One is our protocol is really meant to help in the regenerative phase of this particular lung condition, and also to mitigate some of the cytokine storm issues, specifically interleukin-6. Whereas a convalescent plasma treatment is really trying to confer a more global immune response to the patient. So that's a very different type of biologic approach to it. So the short answer is yes, you can combine those together.
Okay, so both convalescent plasma and our protocol, that we can combine this one. And even this protocol, we can use it also by inhalation and by the infusion, right?
Yeah, I prefer inhalation if we can. Right. Again, the reason is that this particular treatment, if we give it systemically, will get through the pulmonary bed very rapidly. And ideally, we would like it to be in the pulmonary bed as long as possible, right?
Okay, that's correct. Okay. So any other person, Dr. John, if you have any questions, so then we will almost done with the meeting.
I have a query.
Yes.
Dr. Chris, Dr. Paulus, you mentioned your intention is your stem cell may block the IL-6 like this, but we have a drug like tocilizumab or even steroid can block the interleukin-6. So why patient choose your protocol where even tocilizumab or the dexamethasone is available?
Sorry for Dr. Naveed Mohsen, his connection is gone, so I'm going to put him on the WhatsApp also. So, well, Dr. Zaman's question is that because we are also using the dexamethasone in this condition, so is this one is a little bit different from the like the protocol which we are using for the stem cells? Is this protocol and that the dexamethasone, is any difference between these two, or why should we use this one? I'm right, Dr. Zaman? Is this your question?
Yeah. Or the tocilizumab, the Actemra, it's also used for the IL-6 block. As this drug is available, because stem cell we use in unmet conditions. So we should have target in COVID-19 because I think it's a high ambitious thinking, because patient is actually do not give you enough time for recovery in case of severe condition. I think in mild case or when the patient is maybe going to deteriorate, then because the parameters give you chance to identify the patient is maybe going to deteriorate, like the CBC, lymphocyte count, neutrophil, or the D dimer, ferritin, like this. If I know, then I can collect the blood and we can wait for the whether we can use. Even after the tocilizumab or dexamethasone cannot make patient do not respond to that, then you can try like we use the convalescent plasma like this. I think in these patients we can use, but uh, when patient in the last condition, actually we have no time to give this. So I think protocol should ready in early stage, but that these patients should have chance of day treating. It's not a case of like the mild case in home treatment. Patient should be admitted in the hospital in the moderate case, and the chance have there is chance of recover or chance to go to the ICU. So if patient after starting the initial treatment in the hospital, with completing the all protocols, the drugs, antibiotics like this, then we in the first sitting or second sitting, the blood should be collected and wait for the whether we can give or not the stem cell. And patient when if go to the ICU or the in the or if need the high flow nasal like this, like 50-60 liter oxygen, then we can decide or we can put the patient in our protocol. Is my opinion. Case selection actually very important.
Yes, Dr. Zaman is right. Absolutely. And this goes to the broader picture. The broader picture is in the algorithm of patient care in COVID-19, where would a protocol like this fit into? When should it be used? And that is a great question. Ultimately, every medical center has to make their own decision at what point it makes sense to reach for it. You're absolutely right. Patients now, fortunately, are responding overall better with corticosteroids, specifically dexamethasone and remdesivir and convalescent plasma. So we have at a minimum, we have three approaches that are beginning to show efficacy and can certainly save lives. The question is, when would you reach for this particular protocol? And again, this is different for different critical care teams. I think, as you mentioned, a very wise approach would be to say, look, we've done convalescent plasma. The patient is on dexamethasone. We have remdesivir. We're giving any and all support that we can give from a standpoint of mechanical ventilation. We're proning the patient. We're doing all the right things. And yet the patient seems to be deteriorating. At that point, I think that would be an ideal place to bring in this kind of protocol. If you're doing this, however, in terms of, let's say, a study protocol in the intensive care setting, in that study protocol, you could bring this particular stem cell protocol in a different fashion. So if it was part of a clinical study, then you can have cohort groups where automatically a protocol like this comes to bear. Even if the patients are reasonably stable, in that scenario, of course, the data collection would revolve around to see, well, will this patient fully recuperate and convalesce from this disease? And if so, in what time frame? And maybe this treatment is accelerating the recovery. But again, there has to be a very wise and thoughtful algorithm of care in the ICU setting that will determine at what point this particular protocol should come into play. Did that answer your question, perhaps, Dr. Zahn?
Yes.
Yeah, excellent point.
Dr. Naveed, do you have any question?
I would like to ask one of my patients who's a bit difficult to treat. He was 33 years old man who had COVID-19 in UAE. So he returned to Pakistan and he was there with symptomatic pneumonia. He never required ventilator support, but he was on full protocol, including HCQ, dexamethasone, and anticoagulants and antivirals. Once he arrived to Pakistan, then he had some kidney issues, so he was referred to me. And on workup, we find out that he is leaking electrolytes in the urine, and he is dropping his serum potassium level and at times serum magnesium level. So the clinical diagnosis on the basis of the urinary indices and the blood indices was made as Gentleman syndrome, and we are replacing the electrolytes. Now, I was just wondering that would we can extend any stem cell therapy or any other therapy other than the conventional medicines that are used to treat digital men?
Yeah, I don't know the entire health status of the patient. It sounds like it's a combination phenomenon. I heard electrolytes were had dropped out, including potassium, etc. And I wasn't sure if that was partly nephrotic syndrome as well, or so if there was a renal compromise in addition to the pulmonary
I will
compromise.
Doc, I will send you the entire, that particular case, so that you can just look through it, and then you can answer, by email to Dr. Dr. Mohsen, right?
Sure.
Yeah, I think that will work. Yeah.
Details, and then we can have a little chat with Dr. Chris, and we can have his expertise. Thank you very much. That's very nice.
Yeah, thank you so much. So, and if anybody has any questions, so then we will continue. Otherwise, we are going to end up the meeting. Dr.
Yeah, Dr. Rosina, Dr. Paulus, I had a question. I have a very good friend that's in the hospital right now. He's a very prominent gentleman from China. Started out with renal failure, 2 weeks into the hospital stay, picked up coronavirus, and now he's on BiPAP, and he has bilateral pneumonia. And would they allow your protocol that you have here? You have the MUSE and the VSEL, et cetera, protocol. Are hospitals using that right now? And or would we have to use like umbilical stem cells?
Yeah, it's a good question. I'd have to research to see in the United States, what it is that we currently can bring to bear under the Right to Try umbrella, and not a clinical trial scenario, which is totally different, But in terms of who's currently using a similar protocol, and that would be primarily in the UAE, they've used a similar protocol in over 2,000 patients at this point in time. And so at least there's global precedence for this, and there's data available. So it's not entirely de novo, which sometimes can be helpful in terms of at least having some background data, some clinical data in hand to say, look, this is not an unreasonable strategy. It's been used in large numbers of patients, and here's the data globally available. That might sway a hospital here in the US potentially, but as you mentioned, I think in passing, it's also a political issue in these hospitals. So at least that, I think, would be something that would be helpful to have some clinical data behind. Apart from that, if it gets into other arenas, we don't have precedence clinical data, but we have simply some in vitro support or maybe some neighboring clinical data support, but not specifically to COVID-19. I think it gets clearly much more difficult. But on the flip side, the more critically ill a patient is, and this is an example of that, I believe, that you just mentioned, I think there might be a bit more levity in terms of a hospital providing an ability to bring in something. Ultimately, it doesn't just go through hospital administration, but obviously also to the critical care team. I think you'd have to literally convince both parties that this is something that will be worth trying. And the more science support behind that we can generate, even if it's not in the exact same realm, but the more general science support we can provide, I think the more likely it is something like that can come into fruition.
I have a last question. Most of the COVID patient, hospitalized patient, got the steroid. But so these steroid usually, the anti-inflammatory and stop the healing process. But the regenerative medicine process is always we invite the healing, not the stopping. So our choice is if you want to apply the regen medicine on the COVID patient, that patient actually already got the steroid. So steroid and regen process, these are actually contradictory. I mentioned, I want to remind you, because if you want to regenerate the ligament, tendon, or the cartilage, steroid is always, we are far away from the steroid. But the COVID patient already getting the steroid in hospital patient usually. So in this case, how you can, you have any hope whether this procedure can help the patient or either X or not?
You mean that, okay, the patient already has steroid, right?
Yeah.
Adding this treatment of the stem cells, so like both treatments will work or not? That's what your question?
Yeah.
Yes.
Yeah. It's a really good question. It's actually a very, very good question to ask, because you're saying, look, on the corticosteroid, dexamethasone is an immunosuppressant. So we have suppressed the immune system. How can a regenerative therapy still help in the context of a depressed immune system? I think that's the question.
Yeah.
And that's a great question. So if you looked at cells, if the assumption was that these cells are meant to survive, the very small embryonic-like stem cells, if they're meant to survive in the environment we're delivering them into, and not just survive, but engraft, if that was our hope, there is no doubt that corticosteroids will inhibit that to some degree. It would make it harder for a cell population to survive and engraft in that environment. There's very little doubt about that. However, what will actually happen is when we aerosolize these types of cell populations and delivering them into the alveolar environment of the lung, what will happen is their survival will still be rather short term, but while they are surviving, while they are alive, they will secrete their secretome. So there will be exosomes that will be secreted by these cells while they're alive. Ultimately, the corticosteroid will not affect the cytokine profile of the secretions from the stem cells, but it will certainly inhibit their survival. There's no doubt about it. And so the ideal environment would be to deliver this therapy not when a corticosteroid is given, but it is only going to diminish its effect partially. It will not entirely diminish the effectiveness of the therapy, because again, it's the secretome, the secretions from these stem cells while they're still alive, that protein content will ultimately still be there and go to work. But it's an excellent question, and there's no doubt that it's not ideal to have a combination of a corticosteroid and a regenerative therapy, but it will only partially affect it.
So you mean that in that scenario, like we can give them by inhalation so that the stem cells can act only on the alveoli level, right?
Yeah, and that was the idea with this very small population as it is. We have to aerosolize them. But again, I think this is a very elementary question. And, how does dexamethasone really affect this therapy? And I do believe that it partially will inhibit it, but I think it'll be rather partial at the end of the day. It's national or international guidances that seem to conflict with some of the things we're talking about. And we'll have to find a way to work around it and provide the best care for our patients we can. You can still administer this treatment systemically. I think the benefit may not be quite as profound if you did so, and we may have to change the dosing regimen. In other words, we may require more volume of the particular biologic to get at least some concentrating effect in organs. So we may end up having to modify the volume based on that if we give it systemically.
Yeah,
That's a good point.
But the doc, how then the UAE has done this inhalation and all this stuff. So how that happened?
Yeah, I don't know. I think that ultimately, the World Health Organization right now, I think has a difficult time with their global standing. I think it's become, unfortunately, a bit politicized and a bit controversial. And, I don't know, honestly, where the truth lies in that. But at the end of the day, what I do know is that individual countries are now in a fight, literally in a fight for their patients, and also, in a fight for their population from a public health perspective. And I think literally countries are having to go their own path in hopes of helping themselves. And WHO guidances are very important still, but I think what has happened is that from a political scenario, that countries will more likely say they will adopt their own internal guidances and not necessarily follow everything that WHO puts forth.
Okay, so should we end the meeting? Agree? Everybody agree?
Yes.
Okay then. Okay, thank you, Dr. Chris. Thank you, Dr. John, Dr. Zaman, Dr. Ghafoor, and Dr. Naveed Mohsen is on WhatsApp. So anyway, thanks all of you. And yeah, thank you.
Thank you, everyone.
Thank you.